Welcome, everyone. I'm really glad that you're here with us today. And next slide. So before we start, I just out of recognition and respect, I want to acknowledge that we live and operate on unceded land of Indigenous peoples throughout this US. To date, there are 574 federally recognized American Indian and Alaskan Native tribes and villages, and over 100 state recognized tribes. There's also approximately 245 non-recognized tribes that are in varying degrees of petitioning towards federal recognition. A land acknowledgement is one act to acknowledge the land and Indigenous peoples and their relationships with their traditional territories. The acknowledgement becomes meaningful when it's coupled with authentic relationships and informed action. I encourage all of us to identify the land that you are on and develop an understanding, a recognition, and accountabilities to the Indigenous people of the land you reside and work on. I reside on the traditional territories and ancestral homelands of the Nisqually, the Coast Salish, the Cowlitch, and the Chehalis nations. Thank you. So the Population Health Innovation Lab is a program of the Public Health Institute, and we focus on supporting the success and impact of health-focused multi-sector collaboratives. And in particular, we've spent a fair amount of time hanging out with accountable communities of and for health. As an innovation lab, we love to use and build capacity and systems change frameworks and practices that support this messy work of creating healthier systems. And in addition, we conduct research that informs our practice. And today, you're going to get to hear about some of this work. Next slide. So the agenda, right? So, I'm providing a welcome. You're going to hear the research. Then we have an amazing panel of ACH representatives from California and Washington. And then Christina is going to host us in a discussion. And what we hope right out of this is that you're going to identify at least one new strategy for advancing equity that can be implemented in your communities. And really just this notion of local context is really, really important. I think some people might think if you do it in one place, it works in another, and it may not, right? So just I'm thinking about how context and power dynamics influence an ACH's ability to advance equity and communicate the importance of keeping local context and power dynamics in mind when you're doing this important work. Next slide. So you're going to hear from some folks from Phil. It was Stephanie Voltema, who is our Director of Research and Network Science, who is also I want to give a shout out, who is really working very hard to finish her dissertation, and she's very close and very proud of her. And I can't wait to read however many the 500 pages. And then you're going to hear from Peter Forberg, who is a research associate with Phil, and Christina Olson, who is a program manager and actually hails from an ACH in Imperial County, California. Next slide. And then Christina is going to actually formally introduce these folks, but I just wanted to name and recognize that we have this great panel here that's going to be speaking to their perspectives in this work. And I think next slide. And then just before I turn it over to Stephanie, I think we just want to acknowledge the 22 ACHs in Washington and California, our funder, Robert Wood Johnson, and the Georgia Health Policy Center. Catchy, I think I saw Barb on here. I think, they've been very, very supportive and great partner in the Washington State Healthcare Authority. So with that, just thank you to everyone, and thank you for being here and listening to the stories and what we've learned. I'm going to turn it to Stephanie.
Thank you, Sue. All right, so we thought it might be nice to start off with a little bit of an introduction to this research. I know that many of you may have some familiarity by now, so we're going to keep this pretty short. but wanted to make sure there's at least a foundation that we're all building from. So today we're sharing some discrete findings from a very large research project that has been underway for just over 2 years now. This research is part of the National Aligning Systems for Health Initiative, which is led by the Georgia Health Policy Center and supported by the Robert Wood Johnson Foundation. And our overall objective for this research is to explore how collaboration and alignment among various sectors in partnership with community residents and tribal nations leads to outcomes in all 22 ACHs across Washington and California. I recognize that some people here today may not be familiar with this term ACH, so I want to provide just a very brief introduction here. So ACH stands for Accountable Community of or for Health. In Washington, they use of. In California, they use for. Both are ACHs. And these ACHs create shared responsibility and accountability for the health of the entire community that they serve. So this nice figure on the page was developed by the Funders Forum on Accountable Health, and it describes the essential elements of ACHs. I do want to recognize that every ACH is different. People often say if you've seen one ACH, you've seen one ACH. But even though that's very much true, you will see different elements, these different elements to varying extents across every ACH. And furthermore, you'll see that equity spans across these elements, that it is at the heart of the ACH model. And so this is one of the reasons why ACHs are the population of study for this big research question. Speaking of the big research question, here it is. Our overall study is guided by these two big research questions. The first being, how can elements of an ACH's local context and collaboration dynamics be combined, enhanced, or mitigated to increase the likelihood of achieving effective outcomes? And we're most interested in 3 different outcomes. The first being cross-sector alignment, second, long-term sustainability, and third, improved equity. That's where we're focusing today, is on improved equity. Our second big research question is, when do certain configurations work? For whom, why, and under what conditions? Recognizing that what works in one community may not work in other communities. And so getting a really granular, intimate understanding of when things may or may not work. So as one part of this big research project, we conducted a sub-study, which we refer to as our deep dive study. And this is where we're focusing today, on the results of this deep dive study. We conducted this deep dive study with 2 purposes in mind. The first was to explore some of the really big and challenging concepts that we learned about in the first year of the research. And these concepts that really stood out as just being big, perplexing ideas that no one really has their arms around are this idea of local context, power dynamics, and equity. And so we use this deep dive study to really get a deep understanding of these concepts. And now we also, through this deep dive study, sought to gain some insight into that second research question of what works in different contexts. And so for that reason, we invited 6 diverse ACHs to partner on this research project. And as you'll see here, they represent different contexts. So 2 are rural counties, 2 are urban counties, and 2 are ACHs that span multiple counties, regional ACHs. And so we sought to work with these ACHs to figure out, okay, how does this work across different contexts? And so from this deep dive study, we ultimately investigated the question, how do local context and power dynamics influence an ACH's ability to make progress toward improved equity? So that's where we're focused today. Before I hand it over to Peter to talk about what we learned from this study, I do want to acknowledge who's represented in this overall research. So today, while we're focused most on the deep dive portion of the research, we will be drawing on pieces from the overall research. And so for that reason, I want to describe who's represented in the full thing. So overall, we've heard from 642 unique individuals, many of whom we've heard from in multiple different ways. We've heard from 85 individuals representing 15 ACHs through interviews and focus groups, close to 600 people through surveys, and we have also collected and reviewed close to 2,000 documents representing all 22 ACHs across the 2 states. And then on the right-hand side here, you'll see the overall distribution of how people are representing different groups, different residential settings, race, and ethnicity. So now that I hope everyone has at least baseline understanding of the research project and what we're doing here, I'll hand it over to Peter to talk about what we found in response to this research question.
Thank you very much for that introduction, Stephanie, and thank you all so much for joining us here today. I'm very excited to be talking to you today about the findings of this deep dive study. And so I want to quickly remind us of this question that Stephanie pointed out is what guided this study. So this deep dive, this in-depth look at equity with 6 ACHs across California and Washington was centered around the question, how do local context and power dynamics influence an ACH's ability to make progress towards improved equity? And we can think of this question as the guide for the research finding. So first, we'll look at local context and then its relationship to equity. We'll look at power dynamics and its relationship to equity, and then we'll look at equity itself and see, generally speaking, what is the relationship between an ACH's work and equity. So with that, we'll first look at local context. Next slide. So local context. What exactly is it when we're talking about local context? Local context encompasses all of the factors that influence the implementation of an ACH within a given community. So if we think about ACH, accountable communities for health, that community part is integral to just the name of it. We want to talk about the locality. What makes the local, what makes the community the community? And some of these factors might be a given geography, demographics, or socioeconomics. It's very easy to think about this in terms of geography and say, is it rural? Is it urban? You can talk about demographics. Is this a place that is racially diverse? Is this a place that is economically diverse? We have a lot of high income, low income, a mix. And how do all of these factors fit together? That is the local context. And so these are different for every community, and each factor is important for an ACH to consider as they seek to understand and improve their community's health and really innovate in the health space. So one example of how we have been tracking this is in the survey. I want to give a quick example of some of the work that we've done. We have this statistic here. 93% of cross-state respondents agreed that systemic racism is a problem in their local community. And so this is just one survey item of many survey items that we use to get at local context. It shows us not only something about the community, but how people feel about their community. So that's local context in a nutshell. It's all of the things that make the local, both what the community is and how people feel about their community. Next slide. And so when we think about the importance of adapting to community, we see that local context can really influence equity outcomes. And we've identified 4 main ways that local context influences equity. First, there's the ability to adapt to shifting public health emergencies. So if an ACH wants to be in the lead when it comes to promoting equity within their health network, it has to be responsive to public health emergencies such as COVID-19 and wildfires. During the study period, these were kind of the most important things. These were the public health emergencies that, while they may seem like they were sometimes national or regional emergencies, it was important that each ACH understood the local context in which things like COVID were occurring so that they could adapt and tailor their response to their community. The next thing that an ACH needs to be considerate of is they need to recognize the tribal sovereignty and inclusion of Native American communities. We also saw that ACHs have to have the ability to acknowledge and respond to systemic racism. And so both of these, we're talking about understanding the people within your community, the needs of diverse groups, the needs of diverse and independent groups within your communities. These are people that you are working with and collaborating with that make up the community and thus also make up the ACH. And finally, there was the ability to convene across the ACH's full geographic scale. In order to produce equity, it was important to recognize that the ACH can span a diverse geography that will include many different stakeholders, and some of these geographies are massive and require different approaches than geographies in cities, which can also be huge and just as diverse. So you have to recognize the geography and exactly what you're dealing with here so that you can scale up and convene people from across whichever territory. And so just as a quick review, these are all things that deeply influenced, these are all aspects of local context that deeply influence an ACH's ability to make progress towards equity. Next slide. And so I just wanted to include this quote here that really, it shows you, we weren't just looking at statistics, we weren't just tallying up numbers, but we were also listening to people who work in ACHs, people who participate in ACHs, who are affected by the work of ACHs. And so I thought this was a great quote that demonstrates really the importance of local context. So I'll just read it word for word. We have major health inequities that are actually the result of racism. So any kind of platform that's adopted has to start with that fundamental premise. It can't be an add-on or a nice to have. It literally has to be what the whole initiative is built on. So when we think about local context, that's thinking about things like racism in the community, the racial buildup of the racial demographics of the community, how those things must be addressed at the outset, at the very structure of the ACH to produce equity. So that's local context in a nutshell. Next slide. Now we're going to talk about power dynamics. And now power dynamics is a term that can have a lot of implications. So again, it's good to get on the same field here and know that we're talking about the same thing. So power dynamics captures the power imbalances that exist between actors within a given community. Power comes from diverse sources, and thus power imbalances may exist due to differences in financial resources, workforce capacity, or representation of historically oppressed groups. Because ACHs aim to convene diverse groups, it is essential that they understand how the relationships between those groups influence an ACH's capacity for effective collaboration. So that's kind of, a big definition, but we can think about it in simpler terms. It's which groups have the influence in terms of money, decisions, who's making the decisions, who has to follow the decisions, if rules are being made, who's making the rules, who has to follow the rules, who's implicated by all of the levels of influence that might be social, that might be politically, that might be economic. That's power dynamics. And that's a difficult thing to get at and was often, one thing that we had to tease out a lot through qualitative information. But one statistic that demonstrates how we aim to get at power dynamics through our survey is here. 48% of cross-state community residents and ACH staff said engagement and work with their ACH increase their sense of power to change or influence their local community to a moderate or great amount. So we're already starting to see the relationship between power dynamics and ACHs. ACHs are a way of letting people get involved in that power, get involved in the way that their community's health network operates. And having, half of the people within a community saying that the ACH gave them some sort of ability to influence their health system is really important to know. It's important to know how people feel empowered within their ACH. Next slide. So how exactly does power dynamics relate to equity? Well, our findings showed that the way an ACH could really leverage power dynamics to ensure that there was equity is first, they could commit to diverse representation of community groups. This just means making sure that many different community groups, be they nonprofits or race-based groups, gender-based groups, whoever it is, that these different groups from different sectors and identities were able to come together and actually work with the ACH. Then there's group capacity. And so this group capacity is all of the ways that an ACH could support these groups so that they were able to actually work with the ACH and produce something. It's great to involve ACHs, but if a group doesn't have the capacity, whether it's the staff or the funding, then there's no way that they can really be involved. This is how it goes from lip service representation to actually getting people meaningfully involved in the work. And finally, there's the varying priorities of different sectors, such as healthcare, public health, or social services. these are something that is really difficult to be cognizant of, but every different group is going to have different priorities. They're going to want to produce different health outcomes, and while everyone's working towards shared goals of a healthy community, people have different strategies and different levels of importance in terms of what they want to work on. So in ACH, it has to be able to recognize these varying priorities and how they play into who's going to be working on what when it comes to working towards equity. Next slide. And so I think a quote that really captures all of this and cuts right through a lot of the jargon that I've used is I think there really needs to be shared decision-making with big institutions, hospital, county, the universities, and people who have been marginalized and oppressed. I think we need to do a better job of listening to their voice and giving power to people who have been powerless, right? So this is really all about, we need to ensure that people are empowered to make decisions and to participate in the ACH. It's from Martha Shanahan. Next slide. So the last thing that we'll be talking about is equity. And this is really, we want to, everyone has different definitions of equity as well. We want to be on the same terms here. So equity includes all efforts to remove structural barriers to an equal quality of life. And in the context of ACHs is focused on health, social, and racial equity, ensuring that people of all races and income levels can lead healthy lives. And so one way that we're able to get at equity, as shown in this statistic, is 90% of cross-state community respondents agree that their ACH effectively promotes equity across their community. So we're looking at how people understand their ACH to be actually working towards equity. And we saw that a lot of people really did see that ACHs were a great vehicle to be able to produce equity within their community. And across different statistics, this remained true. Next slide. So how exactly do ACHs influence equity? Well, we've already addressed how local context and power dynamics can influence equity, and those are deeply related to an ACH work. But generally speaking, an ACH can influence equity by making sure that equity is central to their work by explicitly pursuing equity-focused goals. If you remember that first quote that talked about racism being something that has to be addressed at the outset, it is a fundamental thing. Equity is a fundamental thing that needs to be addressed at the outset. It has to be central to the work. Then ACHs can incorporate equitable processes into their daily way of working. So not just paying lip service to equity, but making sure that there are processes, agreements, procedures that enable equity work to be done. And finally, ACHs can provide equity education that reflects their commitment to equity, making sure that people who they're working with and the community and anyone who really has an interest in the ACH understands what equity is and how exactly the ACH wants to accomplish it. So we have one last quote, next slide, that I think summarizes this all very well. It is a small step, but actually mitigating the barriers to access to treatment, for example, or making treatment or even prevention and early intervention strategies culturally competent and having those available and accessible geographically and to the Spanish-speaking community. So this quote, you're seeing a lot of things coming together. There's been small steps in that direction, whether it's geography, language, ethnicity, those things have to come together. So to finish off the quote, that's what I mean by nominal progress, lifting up those voices, making that more accessible. Just having people know the term equity is a big step. So there's a lot of things going on with equity, but just having that conversation, bringing it together, that produces nominal progress, a step in the right direction. Next slide. So that's all from me in terms of the findings. I'll turn it back over to Stephanie to talk about some of the conclusions and recommendations.
Thank you, Peter. So let's just briefly touch on some of the things that we've concluded and some of the things that we may venture to recommend as a result of these findings. I do want to note that these are all really high level. There's a lot that's included in this study. There's a lot that's included in the report. And so I'm highlighting some of the most kind of general and hopefully broadly applicable conclusions and recommendations. But for that reason, I want to just make sure that you are aware of the report and go to the report if you want additional details. But broadly, we concluded that local context shapes how aligning works. We thought this may be true, and indeed it is true. What works in one context may not work in another. What we did see, however, is that across these different contexts, the ACH model can be used to align, whether it's in a rural county, an urban county, or a multi-county region. the ACH model can be an effective approach for aligning. We also concluded that power dynamics influence how people, organizations, sectors, and groups interact. And just by that list of all of the interactions there gives you a sense of that complexity that Peter was speaking to. We saw that ACHs are uniquely positioned to balance power dynamics by facilitating power sharing across these different individuals and groups. But we also saw that ACHs should proceed with caution, because we've seen that just as ACHs can balance out power and help share power across these different groups, they can also reinforce or exacerbate existing power imbalances in communities. And so paying great attention to power dynamics and recognizing it as a thing to be mindful of is really important. We also saw that ACHs are making progress toward equity. We saw this across all of the communities, that they are keeping the focus on equity in a way that oftentimes would not have been done if it were not for the ACH bringing equity to the forefront of conversations over and over again. We saw that through this work, ACHs are normalizing equity concepts across organizations, across boundaries, that they're shifting mindsets and practices throughout entire communities. And they're providing the equity education that goes on to influence how people, how organizations think and do their work. So from those conclusions, we would venture to recommend that, and I do want to note that these recommendations are really geared toward ACHs and health-focused multi-sector collaboratives that are doing similar types of work. So we recommend that when it comes to local context, ACHs gain an intimate understanding of the local context and learn how aligning works within it. This is really important when ACHs are partnering with tribes and tribal nations in any way, making sure that they understand the unique differences between tribes and understand tribal sovereignty. We also see how important this is when it comes to intentional community inclusion, making sure that different groups, different communities of like a large region or even a single city are represented in the ACH processes. We've seen the need to gain a data-driven understanding of local context. We've seen that this is often done through things like community needs assessment, which is often done in partnership with local health departments. And this can also be done using approaches like network mapping, gaining an understanding of the systems level interdependencies within a local context. When it comes to power dynamics, we believe it's important to be mindful of these, since they can help or hinder an ACH's goals. A lot of this, as far as our recommendations, come down to representation, making sure that these different diverse groups and perspectives are involved in the visioning or planning processes of an ACH, as well as in governance or decision-making, that representative groups, people are at the table when decisions are made. We also think this is really important when it comes to distribution of investments. And so this could be financial investments where projects are being emphasized, or any other kind of resource investment that's being made by or through the ACH. And then finally, when it comes to advancing equity, we recommend that ACHs continue to keep the focus on equity throughout all activities. And this might sound easy, but it's really complex. We can start at perhaps the most simple one though, which is making sure that equity is named in the vision and mission statements, that at the very base level, it is called out as something that is important. Ensuring that there's accountability for equity, not only of the ACH as a large networked structure, but also of partners and participants who are taking part in the ACH. As Peter mentioned, equitable processes are incredibly important and are some of the foundation for building up equity outcomes. And so ensuring that the processes, the way things are done in ACHs are done through an equity lens. When it comes to projects, ensuring that there's an equity lens throughout all projects, and that any kind of project focus has that equity perspective built into it. And then finally, when it comes to data, just ensuring that Data is informing where equity decisions are being made, and it's used to track equity progress over time. So that's what we've got. Oh, actually, I will say again, please check out the report. I think the link is in the chat. So please check out the report. You will learn more about everything that Peter and I have just shared at a very high level. And you'll also see that there are ideas for action in the report that are based on what we heard is working across these 6 deep dive ACHs. We've included some discussion questions that may be useful for your community, as well as resources related to every topic we've touched on in this research presentation today. So before we hand it over to the amazing ACH panel, where we'll be able to see how some of these ideas are being actualized in practice, I want to open it up. We have just a few minutes for any questions that folks may have about the research itself. And you're welcome to come off mute, speak your questions out, or put them in the chat, whatever you're most comfortable with. So Ellen asks, is there a finding that really surprised your team? I'll share the first one that came to mind for me, but I would love to hear Peter, Christina, Sue, if anything came up for you, or the ACH representatives who we have on the call who participated in the deep dive, what was interesting to you. But the first thing that comes to mind for me is, we think that racial and ethnic diversity is really, really important. And we know that it's really important. And we saw that when it comes to things like language access, that came up quite a lot. But when it came to actual approaches to advancing equity, those things that we noted around local context, like the things that influence the entire community and beyond, those are the things that when we ask, like, what in the local context really influences your ability to make progress toward equity, those are the things that people always went to. And so that was a surprising thing that some people have noted, and I also thought was surprising that in the places where there's a lot of racial or ethnic diversity, that did not seem to come up as much. But I'm curious for others, what came up for you as a surprising thing?
Hi, my name is Alice Williams. I look bad, so I'm not going to let you see my face. I'm at home. But we started we're a community-based organization, a nonprofit side of a church. And when COVID began, we realized that inside of our community, African-American community, that nobody had really reached out into the senior population that was living in congregate housing. So we formed relationships with a couple of medical entities and went into public housing to do COVID clinics. To date, we've probably vaccinated between public housing and congregate housing over 7,000 vaccinations.
Wow.
My concern is in that process, we have also identified many other issues, socialization issues, comorbidities. And what we're trying to do, what my concern is that we don't just become an entity that's gone in here and attacked the COVID issue and not grow into gaining credence in the medical entities that we know now who has diabetes. We also came back in behind all of that and did screenings and found out, actually had to start sending people to hospitals because of hypertension, diabetes. They were in a chronic situation, but making the connection that we have a purpose now from a grassroots perspective and addressing a public health issue in the marginalized communities.
And Alice, I'm sorry if I missed this, but are you with an ACH?
No, but we have, when I look at the definition, we could almost be one.
Yeah. Well,
in all reality, we could be one. We're now like the go-to place for a couple of the universities when they get grant money and they now want to go into the marginalized public housing communities because we've already garnered the trust. They won't even let some of the agencies come in there unless they see our name.
Yeah, Alice, it sounds like you're doing amazing work, and I would highly encourage you to check out some of the resources around the ACH model, because there's a lot of great stuff out there. And I bet there are some things that could be really useful for your community as you continue to explore this important role that you have. Are there any other questions from folks about the research before we move over to our ACH panel?
And feel free to include those in the chat as well.
Yeah. All right. Well, without further ado, I would like to hand it over to Christina to introduce the ACH panel from whom we have the privilege of hearing today.
Wonderful. Thank you so much, Stephanie. It is a pleasure to be here with you all today. We are going to move on from our overview of kind of the research and the findings around the deep dive and equity section into hearing from some of the true stars who are on the ground doing this work day in and day out. Most of them, actually all of them, were doing this work through the pandemic and facing all the changes and really dealing with the ever-changing world today and how we continue to adapt this model to meet the needs of community. So we are going to hear from 5 different speakers. Each are representing different ACHs, either in the state of Washington or California. They were all part of the deep dive study, which we mentioned, these research findings we just overviewed were part of a deep dive portion. And so we're going to go through them one by one. I am going to provide a brief overview of kind of who the individual is that's presenting and hand it over to them. And we will go through all 5 of these presenters, and then we're going to have an opportunity to be in dialogue with them and ask questions from them, because they are obviously the ones doing this work all day long. And so we want you all to be able to hear from them and to learn from them. And then if time permits, we will be having a little bit more kind of opportunity for reflection and discussion overall as a group. So without further ado, I am going to go ahead and move on to providing an overview of Dr. Sarah McLaughlin. She is the founding executive director and chief executive officer of Healthier Here, which is an accountable community of health working to eliminate health disparities in King County, Washington. She has over 20 years of experience in health, behavioral health, and social services as a clinician, researcher, and policy administrator. Dr. McLaughlin has deep knowledge in managed care and Medicaid programs, evidence-based behavioral health interventions for children, youth, and families, change management, and health and behavioral health policy. Dr. McLaughlin, thank you so much for your time here today. I'm going to turn it over to you to talk a little bit about Healthier Here.
Thank you, Christina, and hi, everybody. It's great to be here. I appreciate the invitation. And again, I'm Susan McLaughlin, and I use she, her pronouns. And if you go to the next slide, because we've already heard how important local context is, I just wanted to tell you a little bit about King County in case you're not familiar with us. We are a single county ACH region and the most populous county in Washington state. We have almost a third of the state's whole entire population, about 23% of the state's Medicaid population. A couple of fun facts geographically, we're 2 times the size of the state of Rhode Island, and we have more people in King County than 16 states in the United States. So we're pretty dense urban area, although we do have pockets of very rural parts within our region. We're also the home to 3 federally recognized tribes, the Cowlitz, Snoqualmie, and Muckleshoots. When you look at King County, this is an important piece of our ACH work. When you look at King County and you look at our averages, we're actually one of the wealthiest and healthiest counties in the entire country. But there are zip codes within our county where life expectancy can be up to 15 years shorter than other zip codes in our county. So we experience some deep health disparities in our region. And we are also incredibly diverse. There's one school district in our region where over 100 different languages are spoken in that school district. So that gives you a little bit of flavor of who we are. If you go to the next slide, I'm going to focus our example on how we operationalize and share power and decision making at our ACH. As you heard from the presentation and the data, this is a core component of what ACHs need to do in order to advance equity and how we work. It's our job to make sure no single sector or organization dominates or has a greater say or carries more weight in our decision making than any other organization. So for us, it starts and stops with how we set our tables. So we make sure that all sectors and voices are represented at all of our tables, from our governing board. I have a 27-member multi-sector governing board, to all of our committees and work groups, and the way we bring folks together to talk about gaps and needs in our region and identify solutions. So there's a little picture on this slide that just shows you that the makeup, and 30% of our governing board, 30% of the governing board includes community members, consumers, consumer advocates, and tribal representation, and another 22% is community-based organizations and social services. So right there, you can see that more than half of the board represents the voices of our community and the areas and communities that are most impacted by racism and health disparities. And that is true. Again, we try to carry that makeup to all of our tables and the way we bring people together. The other thing that we do to make sure that those voices are present at our tables is we provide support. For community members, it's in the form of stipends or transportation support, childcare support, other barriers that might get in the way of them being able to participate in our convenings and in our work. But it's the other thing that we do, though, for our smaller organizations is we provide them support as well to make sure that they can free up the time. Many of these small organizations might have 5-6 staff wearing multiple hats, mostly grant funded, so they can only bill their time if it fits into a grant. And so we make sure we provide resources for them to provide reimbursement for their time to be at the tables as well. So that's one of the ways that we ensure that we have that diversity of representation. And again, at our tables, the largest, richest organization in our region has the same weight, carry the same vote as the smallest organization. Next slide, please. So one of the really important aspects of doing the work and achieving equity is really listening to the people that are most impacted, as I mentioned, by racism and health disparities. And so one of the ways we did that early on in the development of our strategy and our goals for our region is through something we call our Consumer Voice Listening Project. And this is where somebody was talking about sort of the organizations, the small organizations that are trusted within the communities. We believe that to be true as well. And so we really seek to work with trusted leaders and trusted organizations. And so the way we lifted up voices from community and consumers in our region is to actually resource grassroots community organizations to develop a strategy to talk within their community about health disparities, needs, gaps, and solutions for their community members. So we contracted with 34 different community-based organizations in our region that reached almost 3,000 consumers. These are people that were enrolled in Medicaid or uninsured in our region, 40 different communities, and everything was translated, all of our materials, into 15 different languages to reach those communities. We co-created with those organizations a data collection guide that included survey questions, but also focus group questions and interview questions, and so that each community could tailor their data collection mechanism to what worked best for them and their community. Some of these were conversations that were held at already planned community gatherings. Others went door to door and actually talked to community members that they interact with. And then a number of surveys were collected as well. And so once we gathered all that data and pulled it together, we also, and this is very important, truth tested that and brought it back to these 34 grassroots communities and said, okay, here's what was gathered. Does this look right? Help us understand it, really giving them ownership of the data that they collected. And then that has been used to inform what we do here in our region, how we make investments, what kinds of system change, how we want to prioritize system change efforts, and so forth. Next slide. So, and then just a couple of other ways we get to collective and shared decision making. So one of the other things that we did early on is formalize mechanisms to elevate the voices of our community members. So when our ACH was first formed, we had a community and consumer voice advisory group that was meeting and kind of helping to co-design what the ACH was going to look like. Once we formalized, we actually made that a formal committee of the board. And so they, we actually have board members that sit on that and share the Community and Consumer Voice Committee. And it is one of the ways that we bring those voices, and they help inform the work of the board. As an example, they created an equity definition and guidelines for use for our organization. And that was approved and is now being operationalized by our board and throughout the organization. We also in early 2019 formed an Indigenous Nations Committee because we realized that we were really missing some of the voices of our Native and Indigenous people in our region. And so that is also a formal committee of the board, and we work with them directly through the decision-making process. Again, creating space I talked about at convenings for all voices, and transparency is really important for shared decision-making. And then I just wanted to share one more example of one of the mechanisms that we use to make decisions to make sure that all voices are included. And that is how we co-design and co-create things. And when we need to bring things to the board for a decision, it's co-created across our varying committees and then presented jointly to the board, and then the board would approve or not that recommendation. So as an example, we have a lot of money. We've had a lot of money these last 5 years under our Medicaid waiver to make investments in system change in our region. You can imagine how many perspectives and ideas there are and were about how to spend that money. And so we used an investment strategy prioritization process where we had all of our formal committees of the board and our community and clinical partners were convening together and separately in small groups to generate ideas. We created a tool for folks to use that ensured equity was at the forefront of all of our decision making. We actually pulled our 4 committees together for several meetings to run all that through, involve them in the evaluation process of all the ideas that were coming through. And then we were able to bring a joint recommendation to the board around how to make investments that included the voices from our Community and Consumer Voice Committee, the voices from our Indigenous Nations Committee, and then our clinical and CBO partners through other committees that we had in our Finance Committee as well, which are all multi-sector tables. So we really were very transparent. We talk to everybody, we get buy-in and support, and we bring collective recommendations to the board for approval. And that's how we're able to share that power and share that decision-making. So thank you, Christina. That's all I have to say, unless there's any questions.
Dr. McLaughlin, thank you so much for that wonderful overview of things. And I do see some things coming in the chat, and I want to remind people, please feel free to generate questions and things as they come up. We will be having an option for question and discussion after our presenters speak. So I am going to go ahead and introduce our second speaker. As this has been a phenomenal overview of already one ACH and how they're approaching work and different things. So we're going to move on to Sarah BullogDorn, who is our Assistant Director of Health Integration for Better Health Together, which is an accountable community for health that covers 7 counties in Eastern Washington State. She oversees the cross-sector collaboration work of the Spokane Collaborative. She also manages regional partner contracts under the state's CMS Medicaid Transformation Waiver, leads Better Health Together's behavioral health forum and workforce initiatives, and oversees technical assistance for clinical and social determinant partners. She also has a background working directly with health plans and health policy. I'm going to turn it over to you, Sarah. Thank you so much for joining us today.
Wonderful. Thank you so much. We can go to the next slide. So thank you for that introduction. It shared a little bit about Better Health Together. We are an accountable community of health in Northeastern Washington, covering six counties as part of our ACH and 7 as part of our insurance navigation work. We also have 3 federally recognized tribes, as well as a large urban Indian population in our area. We're a little bit smaller than King County, but with just over 600,000 population and a large portion of that on Medicaid. Better Health Together was established in 2013, and we've been an accountable community of health and part of our Medicaid transformation waiver work with a lot of different pieces going on, but we'll just be focusing a little bit on some of our equity work today. Go to next slide. I've included in here our position statement on racism as a public health crisis. This is one of the central pieces that really pushed forward and committed our board to this work. We had been doing equity in different ways. As part of the Medicaid transformation waiver, our state healthcare authority set in some vague and general terms that we needed to be doing some equity work. But I think this point was really a big pivot for our board in 2020 towards making sure anti-racist work and equity work generally was not a piece that was separate, but was fundamentally central to all of the different pieces of work that we carried forward. Next slide. So I am not reading every piece of this. We were asked to kind of focus on an example of a piece of equity work that we did. And so my colleague on the west side gave some examples about how we shifted power. I'm going to focus a little bit more around how we built shared language and understanding about equity. The piece of our work that I'm going to talk about is really focused on how we brought our white dominant organizations into an understanding of equity, why it's important, and starting them on a path of making substantive changes within the health system. But I just wanted to show that there are a lot of different portions of our work, portions that are focused on empowering our community organizations, our impacted populations, funding their work, bringing together healing spaces, caucusing, shifting power in our boards. So, as we talk about the kind of what I'll focus on today, I am focusing in this piece on one thing or 2 things we did around bringing white dominant organizations who make up the majority of our healthcare system to an understanding of equity. Next slide. So what I wanted to share about today are two linked pieces of our equity-centered work. As we were first going through our internal organization journey and then working with our contracted partners, which includes, clinical, our primary care, hospitals, behavioral health, as well as our social determinant of health agencies, we wanted to first do an assessment to help organizations get a baseline of really understanding the current state where they were in relation to key organizational activities and behaviors that advance equity. The results of this equity assessment, we offered both back to organizations on their individual results, as well as putting together a regional results to give Better Health Together a sense of where we might provide specific support towards baselines for opportunities that we needed to kind of look for areas of improvement. The tool itself, we sent out to organizations to send out to all of their employees. We had, I believe, over 800 people completed that, as well as more than that so far who have completed our Equity 101 training, which is kind of the next step in that process. It's a pretty big assessment that we pulled together from a variety of existing tools, but really to be relevant cross-sector. There are a lot of sector-specific equity assessments and organizational assessments, and we wanted this to be something that we could look at a regional picture of this. Following the equity assessment in 2019, we put together an Health Equity 101 training. It's a 10-hour training, usually accommodated over 5 weeks in 2-hour sessions. We have at first offered this across organizations, so multiple organizations coming into the same session. But we have since shifted to it being an organization level. So going into an organization, bringing in as many as their staff as possible, really to introduce equity as a topic, have participants practice engaging in that, getting used to the language, getting used to understanding why it's important, and leading conversations, first us leading them, and then practicing leading conversations around equity to grow, one, their understanding, but also the confidence to raise these equity concepts when they see it in their organization. At the end of each of the 5 sessions as part of Equity 101, BHT provides participants with a teach back guide. It's a summary of the concepts and additional resources and conversation prompts, so participants can if they choose and they're encouraged by us to do so, take them back to their teams, take them back to others in their organization, to meetings of their leadership, of their board, and talk through and spread a common understanding of equity. So within that 5-week session of Equity 101, we talk about what is health, what is health equity, what is the difference between disparities and inequities, what's a dominant culture, what is implicit bias, how might it show up in your organization. There's an entire session just talking about racism, structural racism, examples of white dominant culture, anti-racist behaviors, as well as addressing institutional harm. What does it mean for a system to be perpetuating racism and other types of inequities? And then we wrap up that Equity 101 series with really a customized session based on the organization's progress, their needs, and how they want to translate this into action. And that equity assessment that they've taken is a starting point to be able to see, what are your red areas? What are your yellow areas? Where you're doing well? And where could we make an impact? We are going to be offering the equity assessment again, launching that again this fall. So our intention was to do it every 2 years. We took a bit of a pause with COVID. So we're not entirely sure that we'll have comparable data from 2019 to 2022, in part because so much has shifted and changed in our region. And I'm sure, as many of you have experienced, a lot of staffing can change in 3 years, but we do hope at a regional level, there's a lot of shuffling within organizations, but a lot of folks tend to stay in our region, that we'll still have a regional picture and see where things may have shifted and improved there. So those are kind of just 2 of many pieces of our equity-centered work, but it's really how we helped bring our white dominant organizations up to a place where they're starting to think about how can they change a system by the behavior of their organization.
Sarah, thank you so much for such a wonderful overview of kind of the practical that you guys have implemented in your community. I'm sure there are many people with questions that will be coming up. And again, please feel free to start including those in the chat if you have things coming up. That way our panelists can start thinking about that. We will have that open opportunity for Q&A after the presentations. So I'm going to move on now to introducing Catherine Kitty Bailey from the San Diego Wellness Collaborative. Kitty is a nationally recognized healthcare leader that serves in many roles, among which includes being the Chief Executive Officer of San Diego Wellness Collaborative. This collaborative is a nonprofit organization that brings together stakeholders from multiple sectors to enhance the healthcare system and improve community health. The San Diego Wellness Collaborative serves as the backbone for the San Diego Accountable Community for Health, among other initiatives. Ms. Bailey has extensive leadership experience in building coalitions to address critical healthcare problems. She is also a disruptive innovator and was central to the creation of Neighborhood Networks, a novel business venture that links healthcare organizations with community-based organizations in an effort to address managed care members' health-related social needs and address the social determinants of health. Kitty, I'm going to turn it over to you. Thank you so much for being here today.
Hi, thanks, Christina. Good afternoon, everyone, and looking forward to spending the next 5 minutes telling you a little bit about the San Diego Wellness Collaborative and then describing a specific example of how we have advanced equity. Next slide. So the San Diego Wellness Collaborative, as Christina mentioned, we're a nonprofit organization. We're focused on health equity at a population health level. We do this through collaborative initiatives. So all of our work is done through multi-sector partnerships. And we feel that our lane and our specific expertise that we bring to this community here in San Diego is our community clinical linkages and really helping community-based organizations and healthcare partners work together effectively to achieve health equity. We do that through spreading evidence-based best practices and transforming healthcare systems as well as community systems of care. Next slide. We have 3 initiatives that are housed at the San Diego Wellness Collaborative. The first is Be There San Diego, which is a coalition of patients, healthcare providers, and community members working to improve those root causes for heart attacks and strokes, which are hypertension, cholesterol control, and blood sugar control. We do more upstream work with the Accountable Community for Health, which is a multi-sector initiative focused on redefining our healthcare system to go beyond the traditional walls of healthcare. And then finally, as Christina mentioned, we have started an innovative social enterprise, which operates as a social services MSO. And that creates jobs that focus on deploying community-based workforces through a network of trusted community-based organizations. Next slide. We see all of our work existing on the stream of healthcare that we're all very familiar with. So some of our work is pretty downstream with Be There San Diego, for example. We're actually trying to control and help patient populations manage their chronic diseases such as hypertension and diabetes. And then all the way to upstream where the San Diego Accountable Community for Health is addressing those upstream root causes and hopefully impacting the prevalence so that we can reduce the number of folks who even have hypertension or diabetes. And then in the middle, we have neighborhood networks deploying the community-based workforces. So next slide. So this is something that is a case study around COVID vaccinations. And we know, of course, as you all do, that COVID was disproportionately impacting vulnerable communities and that these vulnerable communities were also not as responsive to the calls for COVID vaccinations. In San Diego County, we had a lot of funding going out to community-based organizations to do community outreach efforts and deploy community health workers for COVID vaccination events and efforts. And we also live in an environment here in San Diego County where, in addition to having a rich array of community-based organizations, we also have 7 Medicaid health plans here in San Diego County that are also working with almost 1 million Medi-Cal members for San Diego County. So it's a little bit about the context that we operate here. In terms of the opportunity, in late 2021, actually in the summer, in the beginning of the summer, we heard that the Department of Healthcare Services, the Medicaid agency, was going to be making a large pot of funding available on a limited one-time basis to improve COVID vaccination rates in the Medi-Cal member population. So that was our context and the opportunity. Next slide. We recognized that with our local context here as the Accountable Community for Health, we have important relationships where we bring together the Medi-Cal health plans, healthcare organizations, and community-based organizations together on a regular basis to learn from each other, to raise up the voices of community members, and to ensure that we're all working in the same direction for shared goals. This new DHCS opportunity was a one-time, very exciting opportunity, but as so often happens, when these big dollars become available and they need to be spent quickly, things start to move very quickly. And this is where we start to see the impacts of power dynamics in our local areas. And I'm sure you're all very familiar with this. When you have a lot of money and very quickly decisions needing to be made very quickly to spend this money with a highly regulated environment, such as the Medicaid environment. So this for us was the real opportunity for us as the ACH to step in and play a role to sort of address these power dynamics and see if we could make things happen a little bit differently than they might have happened otherwise without the ACH in the mix. So what we did is we asked our neighborhood network partners to come together and meet with the Medicaid health plans to talk about what had already been done in San Diego County, so that we were elevating the voices of the community-based organizations and the community health workers who had already been doing such important work the prior 12 months around COVID vaccination outreach. We were worried that those voices would get lost in the shuffle of these big dollars and the need to spend those dollars in a short amount of time by many of these Medicaid health plans who are not just located in San Diego County, but have markets across the state. So once we started convening the partners, having these conversations, elevating the voice of the CBOs, one of the managed care partners actually came back to the table and said, hey, instead of us doing one-on-one contracts with a bunch of different partners, CBOs around San Diego County, why don't we coordinate and do one contract and really leverage the power of those CBOs that you're already working with. Next slide. And so in this 3-month period that we were able to actually receive funding to do this work in a networked way, there were 7 community-based organizations that deployed 19 community health workers. And you can see here some of the outcomes that they achieved working together in the power of a network where over 26,000 outreach attempts were accounted for, created over 283,000 social media impressions, and a total of 11,072 members Medi-Cal members were actually received vaccinations during this 3-month period. And in addition to those actual outcomes that we achieved, we also were able to strengthen the network of CBOs by convening them on a regular basis and helping them learn from each other and build their own capacities to do this work with the Medi-Cal health plans. And through that, we believe we achieved greater equity through raising up those voices and increasing capacity of community-based organizations. So that's one example. And oh yes, we have one last slide. Due to this success, we are actually continuing this work, and we are actually looking forward to the future where there's actually going to be a sustained community health worker benefit through the Medicaid plans in California, and hopefully continuing this networked approach.
Kitty, thank you so very much for that presentation and really addressing the importance of that network of community-based organizations and really empowering them to be a part of this process and a strong voice amidst the chaos that typically unfolds in these crazy situations. We are going to move on to our next presenter, Liz Baxter. So Liz Baxter is the Chief Executive Officer of the North Sound Accountable Community of Health, which works to advance equitable well-being, social justice, and belonging across 5 counties in the northwest corner of Washington, a region that sits on the traditional homelands of the Coast Salish people. Liz has spent her career in positions that build bridges between complex policy discussions and the public's desire to understand and weigh in on these issues. She often plays the role of translator of technical knowledge for those who don't live inside the policy world. Liz is an innovative disruptor of policies and strategies, especially in creating spaces where power is shared, particularly by those who most often have not had the experience of influencing decision makers. Liz, thank you so much for joining us today. We're excited to hear from you.
Thank you, Christina. I am going to just preface by somehow we've been able to bookend this between the recycling guys who came and the mailman is probably on their way, because I have a dog with a really sharp voice. So I'm keeping my fingers crossed that you don't get interrupted by Zoe. I appreciate and I'm hoping that what I do is build on some of what you've already heard and not being repetitive. But Northtown ACH, founded back in 2014 by this very broad cross sector of leaders, and really have been utilizing that experience and the experience of partners as we continue to move forward. So if you go to the next slide, and I know that you all started with a land acknowledgement. I'm putting it here not so much to read it, but to just let you know that this is one of our anchors. This land acknowledgement statement was created by a tribal liaison that we have on staff. And so we hired a tribal liaison, a full-time position back in late 2018, because of the 29 federally recognized tribes in the state of Washington. 8 of them are within our North Sound region. And so having the tribes be a part of both the hiring, the recruitment, the interviewing, and the hiring of this tribal liaison on our staff, and us crafting language to acknowledge this land, the Coast Salish people, which actually extends north beyond the Canadian border, was really important to us. We read this with every public meeting. We start our day, if we have internal meetings, our teams read this, and we talk about what it is we've learned and the importance of our relationship with the 8 tribes. Next slide. And so when we started in 2014, we had a mission statement, and that mission statement was to improve the health of people who live in the 5 counties of the North Sound region. And in the fall of 2018, we started on a tribal and equity learning journey. And that journey has included our staff, every one of our partners, our board members. And we started, our very first session was on the intersection of race and health equity. And as part of this journey, we meet once a month. We go do some deep dive focuses on how the work that we do intersects with equity and with racism and all of the structural and systemic barriers at play. In December of 2020, our board actually said that our mission statement was no longer what we wanted to anchor ourselves on. And so they had this discussion because we have a Medicaid waiver here in Washington. They knew that it was ending at the end of 2021. And they said, do we want this organization to exist beyond the waiver? Should it just stop? Should it continue till the money runs out? Or does it have a reason to continue? And this statement, this purpose statement that they crafted and adopted, is actually now like the thing that all of our programs, processes, our hiring, everything anchors around this. And it's because of the deep dive work that they did around equity, that the reason we exist is to advance this just and inclusive culture. And they have behind that a set of goals that they have attached, which I'm happy to share with anybody who'd like to see that, around us, addressing systemic and structural barriers and how we can move from the inherited legacies to creating new legacies. And you will see that in a couple of the other slides. So if you go to the next slide. So Susan shared Healthier Here. And I think, Stephanie, you might have shown this picture of the state of Washington. Part of the reason that I want to show it again is, number one, most people in the United States, and probably a lot of people in Washington, think that the most northernmost boundary of the state of Washington is Seattle and King County. And there is a lot of Washington that is like beyond Seattle when you're driving up I-5 on the freeway. And I think King County, shares this unique relationship with us in that we have counties and bodies of landmass that sit out in the waterways of the Salish Sea, or the Puget Sound as it's commonly called. And so we've got counties that don't have the ability to intersect with resources and services except via a ferry or taking a flight. And so as we think about how we look at equity, we've had to look at equity through multiple lenses. We have counties that are used to getting resources on a per capita basis. And if that were the case, Snohomish County, which has probably about 2/3 of the population of our 5 counties, that's where all of the money would go. And because of our relationship with partners, Instead, we have a scenario where we always say San Juan County, which people come to visit. It is an amazing, beautiful place, has 17,000 people in San Juan County, that we always work from a base of how do we make something work in San Juan County, because if it works in San Juan County, it'll work in Snohomish County. The inverse is not true. And so just trying to think about how we actually approach the various parts of our region. I-5, if you were looking at kind of the whole left side of our region, there's a major highway that goes, from San Diego up into Canada. And the eastern parts of our counties are very rural, yet the North Sound region is not by itself ever described as being a rural region because of what happens along that kind of major highway corridor. And the 8 tribes, just being in a region where we have 8 sovereign nations and we have to navigate those relationships and power dynamics that are there, where we fully acknowledge we do not have the same power or the same rights as any of our tribes, regardless of how small or large their population might be. That's just a really interesting space for us to constantly be navigating. So if you go to the next slide. So we have now spent 5 years as part of the Medicaid Transformation Project, the first waiver that the state of Washington took on around Medicaid transformation. And we're in between space because they are applying for a renewal of that 5-year waiver. And we had probably close to 65 organizations, both clinical, community-based organizations, tribal health centers, who were part of the work of this first 5 years. And as we were planning for this year, which we saw a bit as a transition year for us, because again, remember, our board said, regardless of if you ever get another public dollar, we want this ACH to continue to exist. We created a framework, this collaborative action network, building on a lot of what Stephanie described as what we've learned, from doing this ACH work over the past 5 years, 6 years, 7 years. And so we have in it a set of commitments, beliefs, and some guiding principles. And so what you see here and on the next slide are things that, in order to be part of this collaborative action network looking forward, partners actually have to agree to this language. They have to commit to this language in order to be eligible to receive any funds that the ACH might be able to leverage. The last year has been a series of some pretty tough conversations of, many organizations are like, yeah, we're there. We agree with you. This is really awesome. And other organizations where we've heard them say, you all spend too much time focused on equity. This is not a part of our day-to-day work. We come along with this because you make us do it. And we've had to say, but in order for you to continue with us, these are the agreements, and there'll be commitments for you and your staff and your work. So this slide, and if you go to the next slide, of just some things that guide us, our partners have to agree to these things here in 2022 in order for us to see them as partners looking forward into the next 5 years. You've heard a lot about tribal sovereignty and things being place-based. We actually use targeted universalism and have done so since that very first meeting we had on the intersection between race and health equity. We are talking about leveraging not only resources that the ACH has, but resources that our partners have. Thinking about this as a bit of a network of networks that, what one partner may have access to might be really different than what the ACH has access to. And so how do we actually work in collaboration? I think Susan used terms like co-create and co-design, and we use those terms as well, that together we actually have more leverage than we think we have. We don't have to fit into kind of the proverbial who's getting a piece of the pie kind of discussion. And then we also have been connected to the Othering and Belonging Institute out of UC Berkeley. We see belonging as not only a vital condition for well-being, but it's a practice. And so how we've created the Collaborative Action Network is a part of us using belonging. We are taking our partners and community leaders and moving them into roles as decision makers and influencers of how does the ACH do its work moving forward. So go to the next slide. So this is kind of how we've laid out the Collaborative Action Network. So if you were looking at what 2022 looks like, we've got these partners who have made these commitments. And then we have 5 initial kind of cohorts that they have selected where they think they've got time, energy, staffing capacity to step in. And they can do that at a level of just learning or actually designing and creating projects and initiatives. And we've also given them the ability to say, you know what, we actually want to lead or co-lead one of these cohorts because we've got both the expertise and this time and capacity. And at the end of this year, really they're looking at, they're going to shape how we use the investment dollars that we have available to us with this end goal. And I'm loving the spacing on this. It's like so fascinating. The all people and places thriving with no exceptions. But the thing that actually runs underneath this, every partner had to commit to the equity cohort. The other cohorts, they could pick one or more of them. And we didn't have any partners who only committed to equity. They all committed to equity plus looking at, food sustainability, equity plus looking at behavioral health or pediatrics care. Like they really are beginning to see the relationship between the work that they do and how it is that everything is anchored in this notion of equity and anti-racism and social justice, et cetera, et cetera. If you go to the next slide. So I wanted to just pull a couple of examples, and this has been probably the hardest thing of this 5 minutes because I have about a dozen examples. So all of that language isn't just external facing for us, it's internal facing as well. And so one of the things that when I moved to this region from the Portland area about 6 years ago, and I was told I would not be able to build a diverse group of staff in the area that I live in. And our office is at the northernmost spot in that 5-county region. And I thought, wow, that's really pretty incredible. And so we have done a lot of work on how does equity, targeted universalism, how do those things play out in how we recruit for team members, how we actually do our hiring process, what does our application look like? We are beginning to talk about whether our application needs to be in more than one language. Why do we require people to do an application through a PDF form and it has to be in English? Can folks where, writing is not within their, primary language, can they actually submit an application by sending us a video describing themselves? It's really asking us to even look internally at some of the kind of structural assumptions we have at play about what makes somebody a viable candidate. And the example I give is that of our last 9 hires, 7 of those speak a second language. And that came about with a decision we made probably mid-year last year that we were going to put on every one of our job postings that we're giving preferential treatment and we'll consider applicants who bring a second language to bear. I cannot tell you what it did is it changed who applied to be a part of our organization. I don't know that it changed how we considered people, but people who would never have considered applying to work with the ACH were sending us their applications because they saw themselves as part of this organization. And a couple of folks on my team know that my goal is that someday we become the ACH where everyone speaks a second language, which would literally preclude me from ever applying to work at the ACH. So, but if we have that as our goal, we will create a place where people in our region, whether they are from Afghanistan, Ukraine, Russia, the Latin countries, that changes who thinks of themselves as a potential partner for this organization. And so we're really focused on that. The slides that I showed you, that language around our shared beliefs and our guiding principles, our expectations is embedded in our contracts. So we have, just like all of you, kind of a standard contract template. Exhibit A is this language about the Collaborative Action Network. And we had to have a very serious discussion with our board because their first question was, if someone doesn't want to sign Exhibit A, but they really are, the go-to place for behavioral health, are you going to tell them no? And after some pretty serious discussion, the board was in agreement that our answer would be, if there's no Exhibit A, there is no contract with the ACH. And that's just a really, really fascinating space to be in. And then around fund distribution, we have some baseline expectations that our funds are going to be focused around communities that have had the greatest impact, how we utilize our staff. We're actually talking about relocating our office to be more centrally located around partners and parts of the region where we know that there's greater impact and greater need. And those have been pretty significant for us. But that notion of, do we give funds that are adequate enough for any organization who wants to do the work to know that they are funded at a level that actually allows them to do the work, came out of this discussion in San Juan County, where they would describe, they have to do tobacco cessation programs and they get a 20th of the dollars that the counties on the mainland get. And so they're just not able to do that work. We do fund distribution differently with our tribal partners, just recognizing that they are a bit in a both and space where they can do the work with the ACH and they also can do work on their own because of that tribal sovereignty. So we have a very specific strategy around how we share funds with the tribes. I'm going to go to like the last slide here, and it is a visual that was created with our partners, and it's almost like every aspect of this has a permission associated with it and an underlying message. So working with the 8 tribes, they wanted to see the cedar trees, the water, the salmon, the orca, the eagle. Those were significant aspects of recognizing this place and having land acknowledgement. The canoe is a representation of the reemergence of the canoe journey. And that is really, tribes who were prevented by law from practicing their own cultural and spiritual practices, and seeing that reemergence occur. The mainland being this welcoming space, but that we always just acknowledge that the air we breathe, the water, that those are all things that are tribal space. And then building around that, both our rural and our, I'm going to call them semi-urban areas up here in the North Sound region, that we have mountains, the waterways, the valleys, the shorelines, that are there in that land acknowledgement statement. These are all really critical aspects for us as we do our work. I have like 8 other examples that I'm going to hold on to for the Q&A period. This notion of sharing power and equity is just, it's a lot of work, and doing that work with intentionality, takes a lot of energy, but it is well worth the effort that goes into it. So thank you so much. I'll turn it back to you.
Liz, thank you so much for just such a rich, in-depth overview of kind of how you all are really being intentional about bringing in sovereign tribal nations in your region, and just the importance and the power that they bring to the table. I really appreciate that, and just thrilled to hear this, and I know others as well are very excited about this. So we're going to move on to our final presenter here, Marvin Aviles. Marvin is a serial entrepreneur, operations expert and consultant in the development of numerous startups. He is the founder and CEO of Visual Ops, a company that provides consulting services around the science of operational planning. He is also the Wellville advisor for Lake County, California, which is an accountable community for health. Marvin has worked for a variety of companies in his past, to include Social Amp, IN2, Oracle, Apple, and Macromedia. Marvin has also served in the United States Marine Corps and is an active volunteer for a number of organizations, including Team Rubicon, which unites the skills and experience of military veterans with first responders to rapidly deploy emergency response teams. Marvin, thank you so much for joining us today. We're excited to hear from you.
Thanks, Christina, for that introduction. Hi, everyone. Really happy to be here. I am coming to you from a position as the backbone organization. So my story and our story that I'm going to share with you is actually pretty interesting. I'm actually part of a program called Wellville, and we are in the 7th year of our work. And Lake County is one of our 5 communities that we've been working with. I'm from the San Francisco Bay Area, so I'm very familiar with the area, and I used to go up there as a child. And I actually think that that relationship has a big impact on some of the work and relationships that I've been able to establish within Lake County. So if you could go to the next slide. So as a U.S. Marine and as someone who specializes in operational planning, I think about always the ops of anything, right? So adapting for greater efficiency and impact is the title of my very light presentation. But I think that I hope that you'll find a lot of interest in the decisions and what I'm going to explain in regards to Hope Rising and my role and actually why I am representing Hope Rising versus a local. Next slide, please. So it's a little off there, but Hope Rising is a 501c3, and basically it's a collaborative made up of all of the key organizations that you would need in an ACH. And that was a vision that I had 7 years ago. And to our success, we have been able to actually establish this organization with the representatives, although those organizations have had those representative change over the years to include Hope Rising. And that's actually part of my story. I'm the technical advisor, but we have lost in the past year and a half we've been on three of our managing directors. And so the board made a decision and asked, would I step in to try to get the ship, moving forward or keeping it on a very straight path. And without a shadow of a doubt, without a question, I stepped in and have been, in a sense, acting as the interim executive director because I've had the most continuous relationship with the organization. But what I want to express there is the power of the board and their decisiveness in making that decision, because it didn't come easy, as you can imagine. And so a lot of politics play into that. And I'll talk a little bit about that. And I think we're going to be focusing a lot on power and power dynamics. Next slide. So as we established Hope Rising, and as I got to know Sue because of her relationship with Catchy and the ACH program, I got very excited because everything that I learned in regards to an ACH was the proper vocabulary and the models and the frameworks that I so endear when I see them, because once you understand them, you can adjust them. But having a starting point and having these frameworks were incredibly so powerful, and it's giving me an opportunity to have a great relationship with Sue and others in the ACH community who I see today, which I celebrate, and I'm glad to see these other presentations. One of the challenges, which is what we all struggle with, is, well, how do you maintain the ACH? What is it that you do to generate revenue or to make the payroll of the people that work at the ACH? And the thinking at that time was that they would do projects, and those projects would bring in revenue through grants, and those grants would sustain the administrative and executive fees that aligned with these projects. One of our more famous efforts, and actually it was pretty much our first effort, is Hope Center. And Hope Center is a 20-bed transitional housing in Lake County facility that provides a 360 wraparound services and can help people, and has had a lot of success. So out of the get-go, it was an amazing metric that we are still getting benefit from, in the sense of dollar per dollar, the efforts being put into Hope Center are showing significant results. Out of Hope Center has now come Hope Kitchen, which is the kitchen that fuels and feeds the individuals that are there. And so we are currently working on feeding them, but in an efficient way that represents dollars back into the community. SafeRx, I'm sure that all of you are familiar with some type of opioid reduction or some kind of drug program. That's ours. Smart Start Bright Future is a program that brought in a lot of politics and has been not as effective and again, has brought in a lot of weight into the management. Youth opioid response and All Children Thrive are two other efforts. And the reason why I mention these programs is because, as great as they sound, they are incredibly, and to the point, I would say they are impossible to manage with the staff that we've had. Next slide, please. So what was happening? Project management had a very high cost, right? All of the accounting was just incredibly difficult to manage. The amount of reporting, the labor laws, we actually ended up becoming and we still are, the managing body of the employees at Hope Center, because no one really thought through, well, how are we going to pay these employees that work there? And so now other aspects of that have surfaced, which Hope Rising was not really designed to do. We weren't designed to manage a staff of 15 people that are working at another location in a collaborative environment. We have had payroll issues. We were not the subject matter experts in any of these categories. And then came the idea of board member liability. So the board started to realize, like, wait a minute, this is too much. And why was it that the board had all of that power to make these decisions? And is the board the right group of people to make a decision about the Hope Center and the day-to-day activities that go on there? Or whether a teacher doing Smart Start Bright Future should report to Hope Rising. All of these dynamics surfaced, and the board said, wait a minute, we got to stop. Next slide, please. And so I say that we lost focus, right? We actually went from trying to have impact to becoming an admin and operations organization. That can work in a civilian world where you have investors or funders, or you have a product that you're selling and you're making revenue. But when you're trying to focus on just keeping the lights on and keeping the payroll working, you actually end up losing the initial intent that you were trying to achieve. So next slide, please. So what we realized, and what I realized, and I started seeing it coming, was that we needed to move and get rid of all of these projects, right? We needed to enable other CBOs and NGOs to become owners, to actually be the recipients of the funds directly. We realized that it's much better to facilitate ideas. It was much better to, instead of having 2-hour board meetings that were kind of just report outs of all these projects, why don't we just have an hour board meeting that actually is very well prepared and very decisive, with maybe multiple points of views on a specific topic? And that's what everyone got very excited about, because they realized, you're right, Marvin, let's just focus on facilitating, right? Allow the SMEs to become and exercise their expertise. And the local organizations started to really buy into this idea. So one of the impacts of that is that we've had a 13-member board that originally was about these projects. And believe it or not, that was actually limiting, because the mindset was about the board members. If you have 13 members on there, it's too hard of a vote, and we can't add any more. And so it didn't allow for proper representation of other aspects of the community, specifically the equity part, whether it's tribal, whether it's Latin, which are the two major demographics that we have in Lake County. And as we've made that change, we just came out of, 2 weeks ago, Wellville holds a yearly gathering. We came out of an amazing 3 days where tribal showed up in a way that they have never had the opportunity or made the connection. Our Latin representatives showed up and also had voice. And what was amazing was our chairperson of Hope Rising extended invitations to both of these organizations to come and start participating in our board meetings and to be at the table. Because again, it was not about power anymore. It was about how do we get the word out, but more importantly, how do we facilitate versus own? And so now the driving factor has been really, as we are ending, we are a couple months away from filing the final CHNA after the reviews and moving to an organization that supports the CHNA and facilitates the chip. And because of our relationship after COVID with our Department of Public Health, which is, we really worked closely with them during that period of time, they are now asking us, can we continue working together? And they will provide some funding for us in order to facilitate the chip and having it move forward. So I'm ecstatic because we are removing all of this administrative project management into the organizations that rightfully should have owned them in the first place, our local CBOs and NGOs. But we have our board members that recognize now the power of facilitation if done correctly. And so my respect goes back to that administrative aspect, operations, and really trying to bring value to all of the board members and more of them through a very specific layer of admin and ops. Next slide, please. So that's our current position. We are still moving these projects out, which is not easy. It has a lot of political implications, but what I'm excited to say is that the board believes in this, and having them believe in it makes my job easier. And hopefully at the right time, we can find an executive director that will have an easier time moving the ship forward. So thank you very much.
Thank you so much, Marvin. I really appreciate you providing that kind of overview of the story of where you guys have been and the things that you've realized along the way and the shifts that you guys are making and pivots. It's incredibly important to be able to do those things in this work and to acknowledge when things are going wrong. So I applaud you guys for bringing that to the forefront here, providing an opportunity for people to see that it's okay to do that. So thank you so much. We are going to open it up now for an opportunity to ask questions. We have had such an array of presentations. Thank you so much to all of our fabulous panelists for just sharing your knowledge, your experience, your time today. We do want to make sure that everybody has an opportunity to engage with you. So I am going to invite people now, if you're willing and able, to turn on your cameras. I know it's a little odd, you know, this space of being online, but we'd love to see you all at this point, and we'd love to open it up to any questions. So feel free to drop those in the chat or unmute yourself. We would love to hear from you if you have something specific for someone or just the panel at large.
This is Liz, and if I can just take the liberty of starting, Marvin, I just really appreciated the framing that you gave, because one of the things that we had as an expectation back in like 2015, 16 was that the ACH would do community engagement, and we would struggle with like, but why does anybody need to know like what I do? If I'm the convener facilitator, and really there are so many other people that are doing the work, like what community needs to understand like what an ACH is? And so when this panel started, it was that we were the stars. And I have to say, I struggle with it because I think, I don't know, I'm kind of the shepherd of a lot of stars in my community. But there were just a number of things that you brought up that I just really appreciated, because
Listen, Liz, thank you. There's much more to it, but it's 5 minutes. And there's so many great stories that I'm happy to go into, and I'm jealous of your slides, by the way, but yes, a lot of politics, a lot of ego, right? And as Wellville, I have tried my best to stand behind and not in front. So I've tried to be as quiet as possible.
Thank you for opening us up with those comments, Liz, and I appreciate that reality check and acknowledgement that you all are shepherds in this space. You are stars in our minds because you are absolutely doing this work and helping to shepherd it, but there are so many other stars a part of each of your process. Does anyone have questions? We're not afraid of silence here at the Population Health Innovation Lab, so we're going to let everybody stew here for a moment. All right, well, I'm going to ask a question that came up for me as I was listening to these presentations. And I think that is something that many communities grapple with. And I heard it a couple times across different presentations, just about the notion of inclusion at these decision-making tables of a wide array of people's organizations, representatives, and all having equal power across that table. And I know that one thing that some communities grapple with is the size of this table. I heard Dr. McLaughlin talking about they have a 27-member committee and decision-making body. Marvin, I heard you guys talking about a smaller group. And so, I think that's something when people are talking about the ability to integrate these more diverse organizations and these individuals, how do you grapple with that? For those of you that have had larger tables of decision-making peoples, how do you navigate those waters? Because that is allowing more inclusivity and not just excluding the smaller community players. So I'm curious to hear from that, or those who are in a smaller table, how are you working on that dynamic of ensuring inclusion?
Christina, I'm going to take a jump since no one else is, because this is something that I've been talking about or thinking about quite a bit. I want to express that what we realized was when it came to dollars and when it came to ownership of the project, they wanted to make the decision. Like there were very few people that they wanted to have, well, no, not everybody should be here, right? As we make this shift, and what we're saying is like, look, we're not going to tell you which project you can or cannot have, but what we will bring is the projects so that you guys can decide where the project goes and where it's best to be. And that way you can bring more people in to listen and understand what the opportunities are. There was a point where Hope Rising was going to be responsible for these projects. And that required, that was a lot of fear. So they wanted to reduce the board. Now the trajectory is different because we're not going to own, but we're going to assist. And so now they want more people there because they want more help in that conversation. So it's interesting because it depends upon that type of what's the cost or what's the resource and what's the expectation. That's where that can really expand.
Yeah, and I'm like nodding. And I think I would add, it depends on what decisions you're talking about. And so if you have a board that feels like every decision down to have you gone to Costco or Best Buy to buy something, like I've been a part of boards that get into the minutia of detail. And for the ACH, it took us a while to get this board not only to a good size, but to a good understanding of what decisions were theirs, what decisions are mine, and what decisions belong to the community. And that was like not a flipping a switch kind of a thing. When I was hired, we had a 37-member governing body who didn't know that 37 names had been sent to the Secretary of State and they were the founding board of directors. My very first board meeting, I had to let them know they all had fiduciary responsibility for this organization. And they actually gravitated themselves. Oh, I'm more interested in like policy stuff and I'm more interested in practical things. I'm interested in governance. And we found ourselves forming different tables for different reasons and trying to be clear on that. And so we now have a cap of 23. We have a 21-member board that 8 of those seats have been in our bylaws given to the one each to each of the tribes. And so I really have like 13 to 15 seats that are filled by everyone else. But the decisions about, so for, as an example, our board will say, Liz, you can distribute up to, $13 million. I do not take the decisions of who gets any portion of that to the board. They've delegated that to me and to community and to other tables. And I'm going to say we're like, our tables are imperfect. And, one of the things that was introduced to us at that very first training on race and health equity is to fail forward. So we're really good at going, here's how we're going to do this. And when it doesn't work, we adapt it, but we acknowledge like we had to change this because that wasn't meeting our own values and principles and such. But I think knowing which tables are for which decisions has been really helpful for us.
Thank you, Liz. And Kitty, I saw you on mute for a second. Did you want to add anything?
No, I think the governance is an ongoing sort of tension that we hold as an ACH, and that it requires a lot of flexibility and it requires a nimble approach. It does not, typical nonprofit governing rules and best practices for boards of directors, I have not found to be very helpful for the ACH. I find that operating in other ways and using other models of governance have been more helpful. And I just think one thing that hasn't gotten stated yet that I think increasingly is my conceptualization of why an ACH matters is to be a countervailing force in a regional healthcare ecosystem, to present a voice and a powered player that is not normally historically been considered. And that then becomes very important in the way you set the tables and who's at those tables, because you're lined up with an ecosystem that already exists, and you're coming in and saying, this is a new way of doing business in this healthcare region. We're going to do business in a new way. And so these are the people I need to come together and have that conversation.
Such a strong comment. Thank you so much, Kitty, for including that. Just at the, you can't change things if you're going along with the normal structure and status quo. So thank you for kind of that realignment to a new system, a new way of thinking that creates new mindsets here and ways of operating. Does anybody, oh, we have a question in the chat. Is anyone using advising councils or committees that are paying for time? Context is a prevailing opinion that we shouldn't expect historically marginalized groups to give away their time. Started a paid group at local public health department and time associated with a plank of the community health plan, or is paid antithetical to principles, anti-ethical, sorry, to principles of organization as an ACH.
As part of our collaborative action network in this period of co-design and co-creation, we are paying partners for their time. And we are paying that based on how many cohorts are they saying they just want to learn, they want to implement, they want to co-lead. We felt that it was incredibly important to compensate everyone so that no one was being asked to give their time freely for this effort. And it again has been fascinating, because what we were saying is we want and need you at the table, but we don't want you to have to like let go of something else in order to be here. And we wanted them to always know they had the ability to financially support whoever they assigned to this process.
So I'll chime in and add that I think this is one of the wonderful natural experiments that occurred, is that the Washington ACHs were fairly well resourced because they came out of the Medicaid program and came with Medicaid dollars, versus the California ACHs, which have been fairly under-resourced and asked to do a lot with a little. And so we have had very few instances where we've been able to afford to pay partners or members of our committees to come to the table. In some regards, I think in some ways we don't even really pay the backbone for the level of effort and work that the backbone has done. And so this has been a very much an effort that has been organic and relied on partners to come to the table without any reimbursement. As we have had more success in terms of coming up with grant projects together, we have been able to financially incentivize participation, give stipends to community members for participating, but that has been a long time coming. I think it's a philosophical goal though, because we recognize, as I said before, if you're going to do business differently in a healthcare ecosystem, you need to redistribute healthcare dollars in a way that recognizes the value proposition offered to an ACH by an ACH and the value proposition to Medi-Cal and our healthcare system as a whole by the CBOs who are doing a major part of labor and probably what we would typically call in our world point of view here in the United States, emotional labor, which typically goes unpaid. And so the more we can find sustainably financial ways to pay that and to recognize it as having a value. So one of our big things has to be turn the value prop of an ACH into an actual payment mechanism. And that's one of the ones why we started a social enterprise. So I think you cannot have these conversations and not start talking about the money. And it's to the bare minimum talking about the money is paying people to show up at your meetings. There's a whole broader box you need to open up and take apart.
Yeah, and thank you for that, Kitty. I think that coming back to the power piece, when you're talking about people who can come to your meetings as part of their work day-to-day job, that's already a shift of power. And if we want to get others to the table, whether you're using stipends or honorariums or something, we have to just recognize there are some people who come because they can carve it out of their day. They're going to get paid for it regardless. And there are others that we want to have come to the table who don't have that kind of flexibility and that kind of resource behind them. They're coming because it's their passion. And that's where I think kind of the equity and the targeted universalism come into play, is how do I make the table a table where everyone can be equalized? If I'm just recognizing I'm borrowing somebody's time, but this person, they're going to get paid no matter whether they speak up or they don't speak. There's a lot of the structural pieces at play there.
Thank you so much, Liz and Kitty, for your insight on this. I do want to field one last question, then we're going to have rapid, quick answers on this one. Unfortunately, it's such a powerful question that's important and central to this work. So I want to make sure we have just a second for this. But what is the trick to getting the anchor institutions and funders to honor and even help to build the capacity of community/residents led tables and to share the power that they have?
Well, I think we're at a point seemingly lately where folks, after the last couple of years, this is now at least a stated goal. Whether or not the stated goal of doing this actually translates into new kinds of actions by funders and anchor institutions is a different question. I don't know that there is any trick. I think it is a series of difficult conversations, not meeting their expectations, and then continuing to build the relationship in spite of unhappy funders and unhappy anchor institutions, because nothing moves as quickly, as is streamlined, or as efficiently as they would like it to happen. And so then you rely on the strength of your relationships to keep the work going. And I always say, if you are not having difficult conversations at your ACH, you're not doing an ACH. So yes, that's just a part of the fabric of an ACH is, yes, these are hard conversations to have.
Yeah, I would just echo that. Like, it's all about relationships and being really clear and true to your goals. And if equity and sharing power are part of what you're after, you have to say it out loud and just have those agreements amongst your partners. I think sometimes we think of anchor institutions also as like institutions that have power. And sometimes we need to upset that dynamic as well. And an anchor institution might be the organization that's best at language access. And those other large, powerful organizations need to come and play at that table. But yeah, I was hoping somebody had the trick. but I think it's about relationship and putting the time and the effort into that.
Thank you, Liz. Thank you everyone for joining us today. Thank you for all of our amazing ACH panelists doing the hard work on the ground. You all are rock stars through and through. If you are curious to learn more about the Population Health Innovation Lab or Phil, please check out our website. We would love to stay in touch with you. Please follow us on Twitter or LinkedIn, and you will see a post-event survey in the chat. We would love to hear your thoughts on how this went today, how we can improve future such events. And again, just thank you all so much for joining this discussion with us today. It has been a pleasure to have this time with you. Thank you.